This is the big slide. So this stuff are the questions. These are usually the questions that I would say 50% to less would get right. So let's go through it. Let's just try and simplify it using the determinants that we have now. Okay, so here's my curve. What happens with exercise? This is the hardest thing to understand here because we have kind of a major exception to the rules that we've been applying. But let's start here. So first off, we have venoconstriction. So if I have venoconstriction, what happens? It shunts more blood back to the heart. The muscles will contract and we'll have a respiratory pump. So overall, we're going to get an increase in preload. Okay, that's the concept. And this can happen because of sympathetic innervation, as well as some other things we'll talk about in the exercise lecture. But the key is venoconstriction increases preload. Okay, cool. We know what that does. That's going to increase my end diastolic volume. So I know it's going to be somewhere out here. The next thing is sympathetic stimulation to the heart. That's going to increase contractility, right, via the beta receptors. So that's going to lower my end systolic volume. So I'm going to be somewhere around here. Now the question is, what happens with the afterload? Well, the thing is, we get skeletal muscle vasodilation. We want to get as much blood into the heart as possible. We don't want the blood in the GI tract. We want splanchnic circulation to undergo vasoconstriction, shunt that blood back to the heart, and the muscles to have vasodilation. And so you might be saying, okay, that explains why there's a decrease in diastolic blood pressure. And up to this point in the video series, every time we've had changes in TPR, they've been synonymous with the systemic vascular resistance, which has been proportional to the diastolic blood pressure. And this whole time, this whole thing has pretty much more or less been proportional to the afterload. But the thing that we're missing here is that we're talking about the left ventricle specifically. And the left ventricle's afterload is going to be affected by other factors as well. Primarily the fact that I have added more blood to the left ventricle and the fact that I've dramatically increased the contractility because I'm exercising. Okay, my heart rate, my contractility, my cardiac output, all that goes up in exercise. And that also increases the afterload to a greater extent than what's happening out in the systemic circulation. So this is the one exception that's very tricky, very testable, that in exercise, I actually have an increased afterload in the setting of a decreased diastolic blood pressure. Also, if I have increased contractility, I'm also going to have an increased systolic blood pressure. So remember, in exercise, you will probably have an increased pulse pressure because remember, pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. Okay, and I know I'm going kind of fast here, but we actually talked about a lot of this stuff in the other videos. So in exercise, I have an increased pulse pressure because I have a decreased diastolic blood pressure, increased systolic blood pressure secondary to this contractility. And even though I have a decreased diastolic blood pressure, I have an elevated ventricular afterload. Back to the point here. The point is, because of this elevated afterload, I'm going to get a curve that kind of looks like this. And you might be saying, okay, but it still doesn't make sense. How come the end systolic volume isn't shifted this way because of the elevated afterload? Again, the contractility is king when we're talking about exercise. So the contractility is so powerful that it actually makes your afterload go up even though you have vasodilation, and it actually makes the end systolic volume go down in the setting of an increased afterload. So the way I remember it is that contractility is king in exercise, and you can't go wrong. Okay, so AV fistulas, we've talked about these a little bit. I put a really nice question out there on one of the previous videos, if you've been following the series, about AV fistulas, and primarily used for dialysis, more or less. But the key is when you take an artery and a vein and you make a connection, all the blood in the artery, that pressure in the artery is going to go into the vein. We're going to get a very high flow into the venous side. We're going to get a vein that's engorged, right, very full. But by doing that, I'm creating another circuit for the blood to leave through. That's lower pressure. So it lowers my afterload. Okay, so if I have an AV fistula, I'm going to expect a lower afterload. I can also expect more blood to return to the heart because I have more blood just dumping into the venous circulation. And so what I'm going to get is, because of the afterload, I'm going to get a decreased height, right? I'm going to get a decrease in end systolic volume. And because of the high flow and the increased preload, I'm going to get an increase in end diastolic volume. And so my curve is going to look something like this. Now, if the fistula is really big, like an aortocaval fistula, this patient might be hypotensive. They might go into hypotensive shock, okay? And that's where you might see an increased contractility, heart rate, which can eventually lead to high output cardiac failure. And I talk about all of this, like I said, in another video where I have a question on this, but just to give you an idea. And then systolic heart failure, you just want to think about, the primary determinant here. The primary issue in systolic heart failure is there's decreased contractility. You have a lower ejection fraction, right? And so you know what contractility does now, right? You know what contractility does on these curves. So if I have a lower contractility, what's that going to look like on my curve? A decreased contractility alone would just change my end systolic volume. Okay, so it looks something like that. However, usually when you get a question on systolic heart failure, you have to keep in mind, if it's a chronic condition, which it usually is in a board question, the contractility is going to be very, very low over time. And what happens is we have a backup of blood. And so that backup of blood is going to increase your preload because you're going to get more and more blood getting dumped into the left ventricle, but you can't really get it all out, okay? And so the body will try to compensate for cardiac output, and so over time, you'll also develop a decreased afterload. So the curve over time, what will happen is the end systolic volume is going to go way, way up, okay, over time if it's more chronic, and it's going to look something more like this. Okay, over time, that end systolic volume is going to get shunted way over here, and your end diastolic volume is going to start to go up from the increase in preload. And as the afterload goes down, this curve might actually shrink a little bit too in terms of its height. All right, last on here is the diastolic heart failure. So this one, I just want to erase this just to be very clear on this one, because this is one that tends to get asked about with one very specific kind of point. And so let me draw you the curve again here. Okay, so my curve is going to look something like this. But the point is, for diastolic heart failure, the point is, remember I told you the ventricular compliance is going to go down over time. There's going to be ventricular remodeling, and so we're going to get a very hypertrophied ventricle. Now remember I told you in the very beginning of the video that this base here represents the compliance. Okay, and as that compliance gets lower, the baseline pressure that I'm existing at basically when I'm going through filling is going to be higher because I can't change my volume as well for a given pressure. So what happens is if I have a patient that has, let's just say they have, isolated diastolic heart failure with just a decrease in ventricular compliance, nothing else, right? Basically what would happen is my curve would just shift up like this. Okay, so my curve would just shift up with a decrease in compliance. But of course, there's other changes that can happen. You can have decreases in preload because the ventricle is so stiff. It can't accommodate the venous return. And so what happens is you get this decrease in the compliance, and then you get a decrease in end diastolic volume. The decrease in end diastolic volume, right, you can see here, is because of the decreased preload. Curve that's sloping up or it's going to exist at a higher level, that's due to the decrease in the compliance.